Care of the patient with a cardiovascular or peripheral vascular disorder. Anatomy and physiology of the cardiovascular system. We will look at three components: heart, blood vessels, and circulation. The heart is not bigger than a fist. It's responsible for pumping 1,000 gallons of blood every day through the closed circuit of blood vessels. It's composed mainly of muscle tissue with a series of one-way valves. It's located in the chest cavity between the lungs in a region called the mediastinum. A mass of and the mediastinum is a mass of organs and tissues separating the lungs and containing the esophagus and trachea. The heart wall is composed of the pericardium, a two-layered serous membrane that covers the entire structure. The serous fluid is between the two thin membranes, which allow friction-free movement of the heart as it contracts and relaxes. The pericardium is also the outermost layer of the heart. The myocardium forms the bulk of the heart. It's composed of the cardiac muscle tissue. Contraction of this tissue is responsible for pumping blood. The endocardium, which is the innermost layer, is composed of a thin layer of connective tissue which lines the interior of the heart valves and larger vessels of the heart. The heart chambers. Well, the heart is divided into right and left halves by a muscular partition called the septum, and the heart is divided into four chambers. The right atrium receives deoxygenated blood from the entire body. The superior vena cava returns blood from the head, neck, and arms. The inferior vena cava returns blood from the lower body. The coronary vein returns it from the heart muscle to the coronary sinus. The right ventricle. It receives deoxygenated blood from the right atrium, and the right ventricle pumps blood to the lungs via the pulmonary valve to release, and when it gets to the lungs, it's going to release carbon dioxide and receive oxygen. The left atrium is going to receive oxygenated blood from the lungs via the pulmonary veins. Then the left ventricle receives oxygenated blood from the left atrium. It's the thickest part of the heart, and it's most muscular part, and mainly because it has to pump blood to the body, and this oxygenated blood goes out through the aorta to all parts of the body. Overall, the heart has two separate pumps. The right side receives the oxygenated blood and pumps it to the lungs, hence pulmonic circulation, and the left side receives oxygenated blood from the lungs and pumps it throughout the body, hence systemic circulation. Heart valves. The heart has four valves. They keep the blood moving forward and prevent backflow. The heart is divided into two atrioventricular or AV valves located between the atrium and the ventricles. We have a tricuspid valve, which separates the right atrium and right ventricle. It contains three flaps or cuffs. The mitral valve is the left AV valve separating the left atrium and the left ventricle. The mitral valve has two cuffs, hence bicuspid valve. Chordae tendineae, it connects to the AV valves to the walls of the heart, and it works with the papillary muscles which are located in the walls of the ventricles to make a tight seal to prevent backflow when the ventricles contract. Two other valves are semilunar valves, which are located at points where the blood exits the ventricles. The pulmonary semilunar valve is located between the right ventricle and pulmonary artery. Blood is pushed out of the right ventricle and travels to the lung via the pulmonary artery. Aortic semilunar valve is located between the left ventricle and the aorta. When the left ventricle contracts, blood is forced into the aorta and aortic semilunar valve closes. Both semilunar valves have three cuffs that resemble a half moon, hence semi, half, lunar, moon. Electrical conduction system. The heart muscle tissue basically contracts in a rhythmic pattern called automaticity. The heart responds to a stimulus in the same way nerve cells do. This is called irritability. The SA node, or sinoatrial node, is a natural pacemaker, and it initiates the heartbeat. It's located in the upper part of the right atrium, just below the opening of the superior vena cava. Impulses are passed from the SA node to the AV node. The AV node is located in the base of the right atrium. It slows the impulses to allow the atrium to complete contraction and to allow the ventricles to fill. The bundle of His is a group of conduction fibers. Next, impulses go to the Purkinje fibers, and they are the smaller branches of the right and left branches of the AV bundle, which surrounds the ventricles. The conduction pathway is basically SA node to AV node to bundle of His to right and left bundle branches of the AV bundle and to the Purkinje fibers. The cardiac cycle. It's a complete heartbeat. Two atria contract while two ventricles relax and vice versa. Systole is the phase of contraction. Diastole is the phase of relaxation. Heart sounds lub and dub produced by the closure of the valves. Lub is the first sound, long duration and low pitch. It's heard when the AV valve closes. Dub is the second sound. It's short duration, sharp sound. It's heard when the semilunar valves close. A murmur is a swishing sound that's heard. It may be a normal functional occurrence produced by rapid filling of the ventricle, or it may be abnormal condition produced by ineffective closure of the valves. Blood vessels. There are three main types that carry blood to and from the heart. And we have capillaries. These are tiny blood vessels joining arterioles and venules, which are very tiny vessels that connect to arteries within the tissues. Capillaries form a network where um, exchange of products and byproducts occur. Arteries are large vessels carrying blood away from the heart to the veins. Veins convey blood from the capillaries and return it to the heart. The heart delivers blood to the arteries, which branch into tiny vessels called arterioles. Arterioles are blood vessels of the smallest branch of the arterial circulation, which delivers blood to the tissues. Venules are tiny veins that link with larger veins and return to the heart. The pattern is artery, arteriole, to capillary, to venule, then to vein. Circulation. Coronary blood supply. The heart muscle itself receives nutrients and oxygen-rich blood to function effectively and has its own blood vessels. Systemic circulation occurs when blood is pumped from the left ventricle of the heart through all parts of the body and returns to the right atrium. Pulmonary circulation. This is deoxygenated blood that now passes through the pulmonary circulation to pick up the needed oxygen. If you need to, review your heart circulation and cardiac conduction pathways and from your body structure material. Laboratory and diagnostic examinations. Diagnostic imaging. This provides a film record of the heart's size, shape, position, and outline of shadows. It detects lung congestion, which indicates heart failure, and pleural effusion, which may be noted in the left-sided heart failure rather. Fluoroscopy. This is an action picture radiograph which allows observation of movement. It's useful with the placement of pacemakers and intracardial catheters. Angiogram. This is a series of radiographs taken after injection of a contrast medium into an artery or vein. This allows visualization of the circulatory process, which aids in the diagnosis of vessel occlusion, pooling in various heart chambers, and congenital anomalies. Angiography. It allows X-ray visualization of the heart, aorta, inferior vena cava, pulmonary artery and vein, and coronary arteries. Aortogram. The abdominal aorta and the major leg arteries are viewed by X-ray. Visualization after a contrast medium is injected through the femoral artery and into the aorta. Cardiac catheterization and angiography. Cardiac catheterization is an invasive surgical procedure used to visualize the heart's chambers, valves, great vessels, and coronary arteries. It aids in the diagnosis and prevention of progression of cardiac conditions and an accurate evaluation and treatment of the critically ill patient. Because iodine is the contrast dye used, screen patient for allergies, of course, prior to administering the dye. After the procedure, assess circulation to the extremity used for catheter insertion. Observe puncture sites for hematoma and bleeding. The patient lies supine with the affected leg extended. Compression device over the pressure dressing at the insertion site is used to prevent hemorrhaging. Monitor pedal pulses frequently after this procedure. Electrocardiograph. This is a graphic study of electrical activities of the myocardium to determine transmission of cardiac impulses through the muscles and conduction tissue. There are three distinct waves or deflections noted. The P wave represents depolarization of the atria. QRS complex represents the depolarization of the ventricles. T wave represents the repolarization of the ventricles. Atrial repolarization does occur, but is not presented. It's basically covered by the large QRS complex. Cardiac monitors. This is a device that allows continual assessment of the heart's electrical activity of patients who are known or suspected to have dysrhythmias or acute cardiovascular symptoms. Telemetry is a device worn by the patient. The electronic transmission of data is sent to a distant location called a home unit or a med-surg floor. Pay close attention to electrode sites on the anterior thorax. Ensure a constant tight seal between the electrodes and patient's skin and any development of skin impairment. Inform telemetry team if patient is disconnected from device. Do not remove and allow patient to shower without provider's orders. Thallium scanning. Thallium 201 is an intracellular ion that's actively transported into normal cells. If an ischemia or infarct is present, the thallium will not be picked up. Inadequate perfusion will be displayed as a dark area on scanning, and that dark area is called a cold spot. It's given via IV while the patient exercises on a treadmill. The AKA for thallium scanning is thallium stress test. Echocardiography. It uses high-frequency ultrasounds directed at the heart. The reflected sound, or echo, is graphically recorded, outlining size, shape, and position of the cardiac structures. It's used to detect pericardial effusion, ventricular function, cardiac chamber size and contents, ventricular muscle and septal motion and thickness, cardiac output or ejection fraction, cardiac tumors, valvular function, and congenital heart disorders. PET scans, or positron emission tomography. This is a computerized radiographic technique that uses radioactive substances to examine the metabolic activity of the various body structures. Patient inhales or is injected with a biochemical radioactive substance. The color-coded images reveal organ metabolic functions. It's used to study dementia, stroke, epilepsy, and tumors. PET also accurately detects CAD non-invasively in an asymptomatic patient, which prompts early intervention once discovered and diagnosed. Blood cultures. They detect growth of bacteria in the blood, and they are crucial to the diagnosis of ineffective endocarditis. CBC, or complete blood count, determines the number of red blood cells, white blood cells per cubic millimeter, also white blood cell differential, platelets, H and H. Low hemoglobin indicates anemia. Elevated red blood cell indicate body is compensating for chronic hypoxemia, often noted in heart failure. Elevated white blood cells indicate infection or inflammation. Coagulation studies is useful in monitoring patients receiving anticoagulant. Drug therapy, which are prescribed for patients with MI. It's important for patients with chronic AFib or atrial fibrillation who are undergoing cardioversion, which is the restoration of the heart's normal sinus rhythm by delivery of a synchronized electric shock through two metal paddles placed on the patient's chest. Now, these studies include PT, INR, and PTT tests. Erythrocyte sedimentation rate, or ESR, is used to monitor or rule out inflammatory infective conditions. ESR is elevated with myocardial infarction and ineffective endocarditis, and ESR is decreased when healing begins. ESR also indicates the extent of inflammation and infection and rheumatic fever. Serum electrolyte tests. Okay, so we have well, bear in mind that it focuses on the body's balance of sodium, potassium, calcium, and magnesium, which are necessary for myocardial muscle function. Sodium maintains fluid balance. Potassium is required for relaxation of cardiac muscle. Calcium is necessary for contraction of heart muscle. Magnesium maintains the correct level of electrical excitability in the nerves and the muscles, including the myocardium and the cardiac conduction system. The MD compares these labs to EKG changes. Serum lipids, and bear in mind that the normal serum triglyceride level is less than 150 milligrams per deciliter. As always, you need to bear in mind all your lab values and rationales. So serum lipids are associated with vascular disease, particularly CAD. Density levels of lipoproteins vary according to the protein to fat ratio. An elevated HDL, which is a high density lipoprotein, is desirable. What's the desirable total cholesterol level? That would be less than 200 milligrams per deciliter. Arterial blood gases, or ABGs, are measured to monitor oxygenation and acid-base balance. This test determines the blood oxygenation, a process and evaluation of the patient's and cardiac failure. Serum cardiac markers. As a result of necrotic heart muscle after an MI, certain proteins are released into the blood in large quantities. Markers like cardiac serum enzymes and troponin 1 are important screening diagnostic criteria for an acute MI. CK, or creatinine kinase, and CKMB, which is creatinine phosphokinase, are the cardiac markers used as the gold standard. Troponin 1 is a myocardial muscle protein released into circulation after myocardial injury. Myoglobin is a cardiac serum marker that's released into circulation within a few hours after an MI. B-type natriuretic peptide, or BNP, is a neurohormone secreted by the heart in response to ventricular expansion. An elevated BNP is greater than 100 picograms per milliliter. It indicates heart failure. The BNP correlates well with the left ventricular pressure. Therefore, the greater the BNP level, the more severe the heart failure. Example is, if it's greater than 700 picograms per mil, it's a decompensated heart failure. Know the levels to determine whether it's none, mild, moderate, or severe heart failure. So BMP levels that are less than 100 picograms per mil reveal no heart failure. BNP levels that are 100 to 300 picograms per mil suggest heart failure. BNP greater than 300 picograms per mil is mild heart failure. BNP levels greater than 600 picograms per mil indicates moderate heart failure. And BNP levels greater than 900 picograms per mil is severe heart failure. Homocysteine. This is an amino acid produced during protein digestion. If elevated, it indicates a risk factor of ischemic heart disease, cerebrovascular disease, peripheral vascular disease, and venous thrombosis. It promotes the progression of atherosclerosis, LDL deposits, and vascular smooth muscle growth. It's elevated and increased platelet aggregation. The most common cause of the homocysteine elevation is deficiency of vitamin B6, B12, or folate. C-reactive protein. It's produced by the liver during periods of acute inflammation. Uh, C-reactive proteins, or CRPs, presence indicates cardiac event is emerging. Disorders of the cardiovascular system. Normal aging patterns. Well, by age 65, physiologic changes have reduced the efficiency of the heart as a pump, but it still manages to pump adequately. Risk factors may be modifiable or non-modifiable. Non-modifiable risk factors would be family history, close family like parent or sibling who develop a cardiovascular disease before age 50 are at greater risk for developing heart disease. Age, CAD and MI occurs most frequently among middle-aged white males. Gender: middle men are at greater risk, or middle-aged men are at greater risk for developing heart disease than women. Incidence of heart disease balances out between both sexes after age 65. Cultural and ethnic considerations. Black men have a higher incidence of hypertension than do white men. Black women have a higher incidence of CAD with higher death rates than white women. Modifiable. Smoking. The degree of risk is proportional to the number of cigarettes smoked. Those who quit smoking decrease their risk. Tobacco has catecholamines like epinephrine and norepinephrine, which, um, if when released, can cause tachycardia, hypertension, and vasoconstriction of the peripheral arteries. Hyperlipidemia. Looking here still at the modifiable factors. Hyperlipidemia, elevated concentration of any and all lipids in the plasma. Density proteins or density levels depend on the protein to fat ratio. HDL, or high density lipoprotein, contains more protein than fat, which serves as a protective function, of course, removing cholesterol from tissues. Desirable total cholesterol level is less than 200. Hypertension. Blood pressure higher than 140 over 90 increases as individuals' risk for heart disease increase. Diabetes mellitus. Cardiovascular disease is more prevalent in those with diabetes. Elevated glucose levels damage the arterial intima and contribute to atherosclerosis. Diabetics also have altered lipid metabolism and tend to have high cholesterol and triglyceride levels. Obesity. Excess body weight increases workload of the heart, of course, and weight reduction programs are needed to maintain ideal body weight. Sedentary lifestyle. Lack of regular exercise has been correlated with increased risk of developing cardiovascular disease. Regular exercise can improve the heart's efficiency and help lower blood glucose levels. Stress. The body releases catecholamines that increase the heart rate and damages heart muscle cells. That's what stress does. Psychosocial factors. People who develop CAD are more likely to have the coronary, prone, or type A personality, with traits that include aggressiveness, competitiveness, perfectionism, compulsiveness, and urgent sense of time. Cardiac dysrhythmias. It refers to rhythm that deviates from normal sinus rhythm, or NSR. Normally, the rhythm is regular with the rate of 60 to 100 beats per minute. EKG reveals a PQRST wave. The P wave precedes each QRS complex. Atrial depolarization or atrial contraction happens here. Then there is a P to R interval. This is the interval between the atrial and ventricular repolarization. There's relaxation going on, ventricular relaxation. QRS complex. Here, the ventricular depolarization occurs, a ventricular contraction. The T wave. Here, ventricular repolarization or ventricular relaxation occurs. Dysrhythmias are an alteration in the formation of impulses through the SA node to the rest of the myocardium, or from irritability of myocardial cells that generate impulses. We will look at the various types of dysrhythmias at this time. Sinus tachycardia is rapid, regular rhythm originating in the SA node. The heartbeat is 100 to 150 beats per minute. Causes are exercise, anxiety, fever, medications, heart failure, excessive caffeine, recreational drugs, and tobacco use. Clinical manifestations include occasional palpitations. Many are asymptomatic. Hypotension and angina are the signs and symptoms presented. If cardiovascular disease is present, this is a normal rhythm and is not usually caused by a heart problem. Sinus bradycardia. This is a slow rhythm originating in the SA node. The pulse rate is less than 60 beats per minute. Causes include sleep, vomiting, MI, intracranial tumors, drugs, especially digitalis toxicity, vagal stimulation, can cause sinus brady, carotid sinus massage, endocrine disturbances, and hypothermia. This may be a normal rate and rhythm for athletes, though, and it's beneficial. It's beneficial rhythm with MI because it reduces myocardial oxygen demand. Clinical manifestations of sinus bradycardia are fatigue, lightheadedness, and syncope. Some patients are asymptomatic. Medical management is leaning towards primary cause of the problem and maintaining cardiac output. Atropine may be prescribed to increase the heart rate. A temporary or implantable pacemaker is sometimes necessary as well. SVT, or supraventricular tachycardia. Sudden onset of a rapid heartbeat is what this is. It originates in the atria. The pulse rate is 150 to 250 beats per minute. Causes include drugs, alcohol, mitral valve prolapse, emotional stress, smiling, and hormone imbalance. The cause is not typically associated with heart disease. Clinical manifestations include palpitations, lightheadedness, dyspnea, and angina pain. Medical management focuses on how well the patient tolerates the dysrhythmia and eliminates the underlying cause. Specific treatments may include carotid sinus pressure, adenosine, digoxin, calcium channel blockers like cardizine, beta adrenergic blockers like propranolol, antidysrhythmics, amiodarone, and cardioversion. Atrial fibrillation. This is electrical activity in the atria that's disorganized, causing the atria to fibrillate or quiver. Its very rapid production of atrial impulses characterized by atrial rate of 350 to 600 beats per minute. Causes are cardiac surgery, long-standing hypertension, pulmonary embolism, atherosclerosis, mitral valve disease, heart failure, cardiomyopathy, congenital abnormalities, chronic obstructive pulmonary disease, and thyrotoxicosis. Clinical manifestations include pulse deficit, palpitations, dyspnea, angina, lightheadedness, syncope, fatigue, change in level of consciousness, and pulmonary edema. Decreased cardiac output results in heart failure and shock. A thrombi may form in the atria. Medical management is to treat irritability of the atria, slowing the ventricular response to atrial stimulation, and correcting the primary cause. Goal is to prevent thrombi from forming and becoming an emboli in the body. Um, Specific treatments of pharmacologic conversion is digitalis, calcium channel blockers, cardizine, antidysrhythmics like amiodarone, and anticoags. If a patient does not respond to medication or electrical conversion, catheter ablation is usually used in younger patients. Atrioventricular or AV block. It detects the AV junction that slows or is impaired with conductivity of impulses from the SA node to the ventricles. There are three types of AV blocks. You have your first, second, and third degree. Third degree is the worst and is a complete heart block. Common causes for AV blocks include atherosclerotic heart disease, MI, and heart failure. Other causes may be digitalis toxicity, congenital anomalies, drugs, and hypokalemia. Clinical manifestations are with first degree AV block, no, there's no block. With second degree AV block, vertigo, weakness, and irregular pulse. With third degree AV block, there could be hypotension, angina, bradycardia. The heart rate is in the 30s. Medical management determines the cause of the dysrhythmia. Atropine and isoproterenol may be prescribed. A pacemaker is often needed with third degree AV block. PVCs are premature ventricular contractions. Early heartbeats are noted here in conjunction with the underlying rhythm. It originates from more than one location in the ventricles and can be caused by irritability of the ventricular musculature, exercise, stress, electrolyte imbalance, digitalis toxicity, hypoxia, and MI. The clinical manifestations depend on frequency and their effect on the heart's ability to pump blood effectively. Some are asymptomatic, others experience palpitations, weakness, and lightheadedness. Any other symptoms are due to decreased cardiac output. Medical management focuses on treating this underlying heart condition. Symptomatic PVCs can be treated with beta adrenergic blockers such as Coreg, anti-anginals, propranolol, and antidysrhythmics such as amiodarone. PVCs may be a single event. It may occur several times in a minute or in pairs. They may last long enough to cause ventricular tachycardia and may even lead to death. Ventricular tachycardia. This is three or more successive PVCs that occur, and the rate is greater than 100 beats per minute. Ventricular fibrillation. This is ventricular musculature of the heart that is quivering. It's a medical emergency that's characterized by rapid and disorganized ventricular pulsations. It's caused by myocardial ischemia or infarction. Untreated VTAC or untreated VT, electrolyte imbalances, digitalis, or quinidine toxicity, and hypothermia. Clinical manifestations are the result of no output and include loss of consciousness, lack of a pulse, decreases in blood pressure and respirations, possible seizures, and sudden death if not treated. Medical management for this would be that it focuses on treating this medical emergency, including CPR, defibrillation, and medications like lidocaine or procainamide. Defibrillation is the most effective method of ending ventricular fibrillation, and it should be done within 15 to 20 seconds of onset to prevent brain damage. Assessment would be subjectively would be, of course, palpitations, skip beats, nausea, lightheadedness, vertigo, anxiety, dyspnea, fatigue, and chest discomfort. Objectively, data includes dysrhythmia of EKG, syncope, irregular pulse, tachycardia, and tachypnea. Nursing interventions and patient teaching. Focus is symptomatic relief, promoting comfort, relief of anxiety, emergency action as needed, and patient teaching. Assess patient by taking the apical rate for 1 minute. Explain the diagnostic and monitoring devices that might be in use. Monitor heart rate and rhythm. Administer antidysrhythmics per order and monitor response. Maintain a quiet environment. Administer sedation or analgesic medications per order. Administer oxygen per protocol. Explain to patient why they should stop smoking. Avoid exercising beyond tolerance level. Avoid strenuous activities. If patient is in doubt about activity, consult their provider. Rest between activities. Conserve energy for ADLs, which are activities of daily living. Stress management is important also to help promote healing. Cardiac arrest. This is sudden cessation of cardiac output and circulatory process. Conditions leading to this are the lethal rhythms, which are ventricular tachycardia, ventricular fibrillation, and ventricular asystole. Please refer to the diagrams that are posted in Canvas for your viewing pleasure. You need to be able to identify and describe the lethal rhythms. Immediate CPR is necessary to prevent major organ damage. Signs and symptoms of abrupt level of consciousness with no response to stimuli, gasping respirations followed by apnea, absence of pulse, radial, carotid, femoral, and apical especially, absence of blood pressure, pupils are dilated, and pallor and indoor cyanosis may be noted. The goal is to reestablish circulation and ventilation. So remember the ABCs of CPR. A. Open airway. B. Restoring breathing. And C. Restoring circulation. ACLS, which is Advanced Cardiac Life Support, provides early treatment of cardiac emergencies. Artificial cardiac pacemaker. It's made of titanium with computer circuits that control the pacing system. One or more leads are placed into the heart and a lithium battery, which may last up to 15 years or more, is used. A permanent pacemaker's power source is placed sub-Q over the pectoral muscle on the patient's non-dominant side. It maintains a regular cardiac rhythm by electrically stimulating the heart muscles. It's used when medication alone does not manage adverse symptoms and dysrhythmias. Disorders of the heart. We will look at a couple. Coronary atherosclerotic heart disease, basically commonly known as coronary artery disease, such as CAD. It's used to describe a variety of conditions that obstruct blood flow in the coronary arteries. Like atherosclerosis is a common arterial disorder with yellowish plaques of cholesterol, lipids, and cellular debris in the inner layers of the walls of the large and medium-sized arteries. This is the primary cause of atherosclerotic heart disease. Okay, we will look further at the others, which are angina pectoris, myocardial infarction, heart failure, pulmonary edema, and valvular heart disease. Angina pectoris. Angina is a spasmodic cramp like a choking feeling. Pectoris refers to breast or chest area. Angina pectoris is the paroxysmal or severe, usually episodic, increase in symptoms. It occurs when basically the heart muscle is deprived of oxygen, and the most common cause is atherosclerosis of the coronary arteries. Other precipitating factors include coronary artery spasm, exertion, emotional stress, eating a large meal, weather like exposure to intense cold, especially circadian rhythms in the early morning or right after waking up also. Assessment. Sudden chest pain, substernal pain may radiate to the left inner arm and to the little finger or shoulder to jaw. Cold, clammy, ashen, shortness of breath, weakness, increased blood pressure, and increased pulse. Transient, meaning don't last long. Transient, lasting 20 minutes. Relieved by rest or medications like nitroglycerin, which is administered sublingually. Look for signs of diaphoresis or anxiety as well. Management, a complete workup. Medications like nitro is the most common. Heparin, aspirin is the drug of choice to inhibit platelet aggregation. Calcium channel blockers, beta blockers, and morphine for pain. Invasive interventions include PTCA, which is percutaneous transluminal coronary angioplasty. This is an invasive surgical technique that widens the narrowing in a coronary artery without open heart surgery. Or a CABG, which is a coronary artery bypass graft. Blood flows from the myocardium through the grafts, okay, and that bypasses the occluded coronary artery. Grafts are taken from the saphenous vein in the legs, or the internal mammary artery is used. So the goal of a CABG is to increase blood flow to the myocardium. Stent placement may be performed to treat abrupt or threatened vessel closure after a PTCA is done. Stents are expandable, mesh-like structures used to maintain vessel patency. Because stents are thrombogenic, the patient must take anticoagulants for at least 3 months. The primary complications from stents are hemorrhage and vascular injury. Less common complications would be stent thrombosis, acute MI, emergent CABG, and coronary spasms. Nursing interventions would be looking at those ABCs, maintaining those ABCs. Um, Small, frequent meals, rest periods, because remember now it's relieved or made better with rest. Explain to the patient the importance of not exerting themselves and administering meds per order. Monitor vital signs, I's and O's, assess respiratory status, and allow verbalization of concerns and feelings. Patient teachings, we want to avoid large meals. Overeating increases the workload on the heart. Avoid extremes in temps. Cold weather constricts coronary vessels to conserve body heat. Therefore, angina pain may develop more easily. No caffeine, no tobacco products. Take nitro prior to activity that may trigger angina. Keep nitro with you at all times. Keep it stored in a brown bottle, a new bottle each month. And if pain is not gone after taking 3 pills 5 minutes apart, seek medical help. Myocardial infarction, or MI, or heart attack. One or more branches of coronary arteries become blocked and the heart tissue dies or infarcts as a result of the coronary occlusion. The blockage does not spontaneously resolve. The severity depends on the location, size, collateral circulation, and the time of presentation. Four most common locations of an MI would be anterior, lateral, septal, and inferior areas. Assessment and clinical manifestations. We will perform a rapid history and physical. The patient may have awakened with pain. The peak time is between 6 a.m. and 12 noon, and many occur during the winter months. Sudden, severe pressure-like pain that increases over time may occur, and the patient may use a closed fist to describe the pain. They may also present with GI symptoms rather than chest pain, especially with women. A rapid weak pulse, elevated blood pressure, this is the catecholamine effect. Diaphoresis, pale, ashen color, clammy, and a sense of impending doom. The blood pressure may rapidly decline as the cardiac output decreases. Nausea or vomiting is the most common symptom of inferior MI. The temperature will rise within a few hours of onset. Ventricular arrhythmias may be noted. Crackles auscultated. Peripheral edema, pain, retrosternal, and pain also in the heart region, often radiating down to the left arm and to the neck, jaw, and teeth. Anxiety may be experienced, erratic behavior, and shock. Also, there may be a sudden onset of prolonged duration. Diagnostic studies include a 12-lead EKG. This indicates an MI with elevated ST segment and inverted T wave. Cardiac enzymes are done and isoenzymes, especially looking at CKMB, or creatinine phosphokinase. That is a serum cardiac marker that is released into the vascular system when the infarcted myocardial muscle cells die. LDH, or lactic dehydrogenase, is elevated in the presence of an MI. Troponin 1 is a sensitive cardiac marker, and it's cardiac specific and is a high indicator of MI. Troponin 1 is. Then we have serum electrolytes, your magnesium, potassium, and calcium. Coagulation studies, and a chest x-ray is done to note the size and configuration of the heart. Treatment. Oxygen, pain relief, that's of primary importance, and it's to have to bear that in mind. Nitroglycerin, magnesium sulfate, aspirin, and heparin decreases the thrombus formation. Morphine and Valium for pain and anxiety. Beta blockers to help decrease the myocardial oxygen demand, especially propranolol. Thrombolytics may be given to restore blood flow of the MI, which occurs within 30 minutes to an hour duration by dissolving the blood clot, especially the streptokinase or streptocase, which is a thrombolytic, and remember it's aka clot buster. But primary importance, we want to decrease the workload of the heart as well. Decreasing the workload of the heart. Nursing interventions for MI. We want to check vital signs. Cardiac rehabilitation is the first stage of recovery. Increase activity gradually. Long periods of undisturbed stress. Pain medication per order of the MD or provider. Stool softeners, laxatives to prevent straining, which will bring about the Valsalva maneuver, which may cause severe changes in blood pressure and heart rate, which may trigger ischemia, cardiac arrest, or dysrhythmias. The diet will be low fat and low sodium, liquid advancing to solids with the diet, and no caffeine. Patient teaching for MI. Well, the first week after discharge, limit activities of daily living, no driving, rest whenever you feel the need to, gradually add activities to the daily schedule, avoid heavy lifting or straining, typically no more than 5 pounds, avoid extreme hot or cold temps. Exercise a little at a time. Check pulse and slow down if it goes above upper limits prescribed per doctor. Warm up and cool down. Don't exercise after a meal. Wait at least 2 to 3 hours. Don't exercise when tired or in extreme temperatures. Use the nitro prophylactically per order. Stop exercising if shortness of breath is experienced, chest pain, or dizziness. With sexual activity, resume gradually, usually when the patient can do a moderate exercise without chest pain or shortness of breath. Generally, if they can climb 2 flights of stairs at a brisk pace, they could participate in sexual activity. Avoid anal intercourse, however, because this brings about vagal stimulation. And if unsure, always ask the doctor. Complications of MI would be arrhythmias. That's the most common complication. VFib is most likely to occur within the first few hours from onset of the symptoms. Congestive heart failure may occur in the first 24 hours. Cardiogenic shock, which is severe heart failure with a high death rate, may occur. Sudden cardiac death, often the first symptom of heart disease, and if present, symptoms usually are short-lived, lasting less than 2 hours. VFib is the most common arrhythmia that causes death. It's a lethal rhythm. And as I said earlier, you need to know your lethal rhythms, which are ventricular tachycardia, ventricular fibrillation, and asystole. Interventions. CPR if outside the hospital, and call 911 also. If inside the hospital, start the ACLS protocol. The focus is to get the defibrillator to the patient's bedside ASAP. Administer antiarrhythmic drugs per order also. An invasive therapeutic procedure for sudden cardiac death would be a PCTA, atherectomy, stents, or CABG. Nursing interventions would be to monitor for hemorrhage or hematoma formation, monitor for chest pain and arrhythmia, keep the affected extremity straight and still for several hours, force fluids, ambulate patient as ordered, and patient teachings about risk factors should be done. Heart failure, or commonly called or known as congestive heart failure. Here, neurohormonal is a neurohormonal problem that progresses as a result of chronic release in the body of substances like catecholamines, which produce negative effects on the failing heart and circulatory system. Congestion is a symptom not always associated with heart failure, however. With congestive heart failure, it's a complication of the underlying heart disease rather than a disease. Cardiac output does not meet the body's needs here. There's a high mortality or death rate and morbidity, which is sickness rate. Risk for readmission related to the patient's lack of understanding of treatment regimen does occur often with CHF. Causes include CAD, hypertension, heart disease, congenital problems, acute MI, arrhythmia, anemia, infection, pregnancy, hypervolemia, and fever. Signs and symptoms for right and left ventricular heart failures are: for the right ventricular heart failure, dependent edema, like ankle swelling, jugular vein distension, ascites, nausea, vomiting, hepatomegaly, splenomegaly, murmurs, anorexia, weight gain, fatigue, chest pain, and rapid weight gain. For left ventricular heart failure, it will be increased respirations, increased heart rate, point of maximum impulse is displaced, cyanosis, frothy pink sputum, crackles, wheezes, S3 and S4 heart sounds, auscultated. There's dyspnea and orthopnea, fatigue, nocturia, and chest pain, palpitations, and arrhythmias. Diagnostic studies include chest x-ray, which will reveal a pulmonary vascular congestion, pleural effusion, and cardiomegaly. Echocardiography would determine a valvular heart disease and the presence of pericardial fluid, heart failure, and ejection fraction. Cardiac catheterizations are done to detect cardiac abnormalities and underlying heart disease. A 12-lead EKG would reveal cardiac dysrhythmias. Enzymes would be elevated. We would test the DH level, ABGs, and potassium level. BNP, which is a neurohormone secreted by the heart in response to expansion of ventricular volume and pressure overload. We look at that. A normal BNP is less than 100 picograms per milliliters, and this indicates that the patient does not have heart failure. Treatment: We want to manage the underlying cause. Drugs of choice would be cardiac glycosides like digoxin, diuretics like Lasix. Vasodilators will be given to dilate the vessels and reduce preload on the heart. Magnesium sulfate will be given to reduce pain, anxiety, and reduce preload on the heart. Oxygen is one of the initial drugs used. Nitrates like nitro. ACE inhibitors like lisinopril was given to decrease the peripheral vascular resistance and improve cardiac output. We want to restrict sodium and decrease the afterload of the heart as well. Nursing interventions would be to assess the patient. Place patient in high Fowler's position, which is an upright position. Um, Instructing patient to get restful sleep as best as possible. Only in a sitting position or with the aid of extra pillows, however. Encourage bed rest to limit the activities to the space they're in. NPO initially, then small frequent meals and progressing with physical activity, strict I's and O's, and monitor the lab values. Dietary management would be sodium of 2 grams daily for a patient with mild CHF and 600 milligrams or less for a patient with severe CHF. Fluids may be restricted in severe CHF patients to control the edema, of course. Foods rich in potassium, especially if they're taking a potassium wasting diuretic. Pulmonary edema. This is the accumulation of extravascular fluid and lung tissues in alveoli. It's most often caused by heart failure. An acute, extensive, and life-threatening complication of heart failure that's caused by severe left ventricular heart failure um, would be the conditions causing the patient to drown in their secretions. Clinical manifestations include signs of severe respiratory distress on initial onset of pulmonary edema. Frothy sputum is produced from the air mixing with the fluid in the alveoli. The sputum is blood tinged from blood cells that have exuded or oozed out of the tissue into the alveoli. Assessment: restlessness, vague uneasiness, agitation, disorientation, diaphoresis, severe dyspnea, tachypnea, tachycardia, pallor or cyanosis, cough, production of large quantities of blood tinged frothy sputum, audible wheezing, crackles, and cold extremities. Diagnostic tests include chest x-rays and ABGs looking at the oxygen and carbon dioxide especially. It could reveal respiratory alkalosis or respiratory acidosis. Medical management: the patient is in high Fowler's position or over the side of the bed with arms supported at bedside table. Morphine is given to patients for pain and anxiety. Oxygen, nitro via sublingual increases the myocardial blood flow. Diuretics like Bumex and Lasix is given to decrease fluids in lungs. Possibly insert a Foley. This allows the patient to rest and conserve energy and monitor urinary output after the diuretic has been administered. And that will allow you to better measure for therapeutic effectiveness of the diuretic. Nitro, this is a potent vasodilator which improves the myocardial contraction and reduces pulmonary congestion. Inotropic agents may be given like Dobutrex or Inocor, and this increases cardiac output without increasing oxygen consumption. Nursing interventions, well, this condition, mind you, is life-threatening and responds to aggressive interventions. Oxygen is definitely one of the first things, drugs that's given. Patient is upright with legs in a dependent position to decrease venous return to the heart. We want to relieve pulmonary congestion and dyspnea, monitor ABGs, and administer drugs as ordered. Auscultate lung sounds often. Explain all procedures performed. Provide emotional support. Monitor vital signs. Fluid, with the fluid, you want to definitely do strict I's and O's and daily weights of the patient and serum electrolytes. Valvular heart disease. Valvular disease occurs when the valves are compromised and do not open and close properly. Two problems are stenosis, which is a thickening of the valve tissue, causing the valve to narrow, and insufficiency, which occurs when the valve is unable to close completely. Valvular disorders primarily are from congenital conditions or from a history of rheumatic fever. Because blood volume and workload of the heart are greater on the left than on the right, the mitral and aortic valves are affected more frequently. There is a table in your book that discusses the clinical manifestations associated, but let's look at some clinical manifestations. The mitral valve stenosis, with that, one would have dyspnea on exertion, hemoptysis, atrial fibrillation, and rumbling diastolic murmur. With mitral valve regurgitation, if acute, is poorly tolerated. If chronic, the exertional dyspnea, syncope, and fatigue may be experienced. Mitral valve prolapse has palpitations, dyspnea, and syncope associated. Aortic valve stenosis has angina, syncope, dyspnea on exertion, and heart failure associated. Aortic valve regurgitation, if acute, with left ventricular failure is experienced, shock, abrupt onset of profound dyspnea. If chronic, fatigue, orthopnea, paroxysmal nocturnal dyspnea, and water hammer pulse is experienced. Tricuspid stenosis would result in peripheral edema, ascites, and hepatomegaly. With pulmonic stenosis, one may experience fatigue. Assessments: assess for a history of rheumatic fever, inability to perform activities in ADLs without fatigue or weakness. Ask patient about chest pain, including the quality, duration, onset, precipitating factors, and factors that provide relief. Heart palpitations, lightheadedness, dizziness, or fainting. Observe the patient for a heart murmur. Note the character and presence of any adventitious breath sounds, like crackles and wheezes. And assess for edema, pitting or non-pitting. There's a table in your book that has a pitting edema scale. Diagnostics: chest x-ray, EKG, echocardiogram, and cardiac catheterization. Medical management: activity limitations, sodium restricted diets, diuretics, digoxin, antidysrhythmics. Surgery may include an open mitral commissurotomy, which is a surgical splitting of the fused mitral valve leaflet for treating stenosis of the mitral valve, or a valve replacement. And this is just the replacement of the stenosed or incompetent valve with the bioprosthetic or mechanical valve. Nursing interventions and patient teaching include identifying and assisting with ADLs that cause fatigue, discuss rest periods for patients to include throughout their day. It's associated with decreased cardiac output, and promote comfort. Do all that you can to promote comfort. Administer meds like diuretics, DIG, and antidysrhythmics. Record I's and O's, daily weights, respiratory rate and rhythm. Auscultate breath and heart sounds and blood pressure. Check capillary refill, pedal pulses. Presence of edema. Sodium restricted diet for control of edema. Maintain oxygen per order. Discuss the disease to the patient and associated symptoms to report to the MD. Explain antibiotic prophylaxis to prevent infective endocarditis. Explain the importance of notifying the dentist, urologist, and gynecologist of valvular heart disease, because the patient will be on higher dosages of warfarin after valve replacement surgery. Carefully monitor PT and INRs. Maintain good oral hygiene and make regular visits to the dentist. Inflammatory disorders of the heart. Heart failure, mind you, is a serious and rapid result of inflammatory processes. There are several inflammatory disorders that we will discuss: rheumatic heart disease, pericarditis, endocarditis, myocarditis, and cardiomyopathy. Rheumatic heart disease is an inflammatory condition, usually a result of upper respiratory infection, specifically with group A hemolytic strep. Usual age that is affected are between 5 and 15 years. It can lead to cardiac problems later in life, especially valvular problems. Signs and symptoms include fever, tachycardia, epistaxis, joint pain or polyarthritis, erythema marginatum, which are red circles and wavy lines on the trunk of the body, involuntary movement of muscles, which are Sydenham's chorea or St. Vitus dance. It's a disorder of the central nervous system. Heart murmur, especially if carditis is present and valves are affected. Diagnosis or diagnostics would be through signs and symptoms, echocardiogram to check the extent of the myocardial damage, EKG to show cardiac dysrhythmias, auscultate heart murmurs or friction rubs, erythrocyte sedimentation rate, and white blood cells are both elevated. ASO titer will show antibodies against strep. The C-reactive protein is abnormally high here as well. Medical manage, well, prevention is the best. You want to treat the upper respiratory infection promptly. Penicillin is preferred. Bed rest until acute symptoms subside if carditis is present. Bed rest is prolonged. NSAIDs for joint pain. Heat for joint pain. A well-balanced diet with vitamins B and C supplements increases the fluid intake. The main goal is to treat the inflammation which can lead to infection. Nursing interventions would be diversional activities, proper positioning to minimize joint pain, and PACE activities. Patient and family teachings include prophylactic antibiotics daily or monthly during childhood and adolescence and before any dental surgical procedure. Educate them on signs and symptoms to report, dietary measures, and activity level at home. Pericarditis. This is inflammation of the membrane sac surrounding the heart. It may be acute or chronic in nature. Manifestations include debilitating pain that is aggravated by lying supine, deep breathing, swallowing, coughing, and moving the trunk. That's when they experience this debilitating pain. Pain is alleviated by sitting up and leaning forward. The hallmark finding is pericardial friction rubs, grating, scratching, and leathery sounds that are detected. Medical management would be analgesia for comfort and relief of pain to reassure the anxious patient. Um, you definitely want to do that. Oxygen and parenteral fluids are usually given. Antibiotics are used to treat bacterial pericarditis. Aspirins are used for increased or spiked temperatures. Anti-inflammatory agents and corticosteroids may be given. If pericardial effusion restricts heart movement, this is called cardiac tamponade. A pericardial tap or pericardiocentesis may be performed to remove excess fluid. Nursing interventions would be to evaluate vital signs, assess heart and lung sounds, maintain bed rest to promote healing and decrease cardiac workload, elevate head of bed to 45 degrees to decrease dyspnea, and remain with the patient if they seem anxious. Explain procedures as well. Endocarditis. It is an infection or inflammation of the inner lining of the heart, particularly the valves. It affects those that are at risk of contracting endocarditis have rheumatic heart disease, congestive heart failure, degenerative heart disease, and they also can follow invasive procedures such as dental work, minor surgery, OBGYN exams, and insertion of indwelling urinary catheters. Signs and symptoms would be flu-like symptoms, petechia, which are tiny red spots that appear under the skin from broken blood vessels of the mouth, conjunctiva, or legs. Anemia, splinter hemorrhages, which are black longitudinal streaks on the nail beds. Weight loss, tachycardia, and a new onset of a murmur. Diagnostics include EKG changes, and chest x-rays may indicate heart failure and enlargement. Leukocytosis, elevated ESR, blood culture and sensitivity tests. Medical managements include complete bed rest with fever and signs of heart failure, massive dosages of antibiotics parenterally, prophylactic antibiotics for those at high risk, surgical repair of diseased valves or valve replacement surgery. Nursing interventions would be decreased physical activity and calm, quiet environments during acute phase, Vital signs including apical pulse are closely monitored when physical activity is increased. Between meal supplements may be given because patient may have decreased appetite during the acute phase. Patient teachings include activity level, medications per order, dietary signs and symptoms to report. You educate them on that. And these signs and symptoms will show evidence of recurrent infections like malaise, fever, fatigue, and chills. Basically, to prevent infection, that's the key, and they will have to take antibiotics per order prior to dental procedures and those other procedures that I mentioned earlier. Myocarditis is relatively rare. It deals with inflammation of the myocardium that may originate from rheumatic heart disease. Signs and symptoms vary. Patient may have upper respiratory tract symptoms like fever, chills, sore throat, abdominal pain, nausea, vomiting, diarrhea, and myalgia. The aforementioned symptoms occur up to 6 weeks before the patient has signs and symptoms of chest pain and overt heart failure with dyspnea. It's typically seen, things that are typically seen with myocarditis would be cardiomegaly, murmurs, and tachycardia. The diagnostics would be EKG, chest x-ray, echocardiogram, and endomyocardial biopsy. Therapy is similar to that of endocarditis. That would be bed rest, oxygen, antibiotics, anti-inflammatory agents, careful assessments, and correction of the dysrhythmia. Cardiomyopathy. This is a group of heart muscle diseases that primarily affect the structural and functional ability of the myocardium. It may be primary or secondary. Primary cardiomyopathy is not associated with CAD, hypertension, vascular diseases, or pulmonary disease. Types of primary cardiomyopathy would be, dilated cardiomyopathy. And this is characterized by ventricular dilation is the most common type of primary cardiomyopathy. Then we have hypertrophic cardiomyopathy. This results in increased size and mass of the heart. Then we have restrictive cardiomyopathy. This is when the ventricular walls are rigid, thus limiting ventricles' ability to expand and resulting in impaired diastolic filling. Types of secondary cardiomyopathy include infective, which may be viral, bacterial, fungal, or protozoal myocarditis. It could be metabolic. It could be severe nutritional deprivation. It could be long time alcohol abuse in large quantities. It could be peripartum related. This develops in the last month of pregnancy. It could be due to drugs, especially doxorubicin or other medicines. It could be due to radiation therapy. It could be due to systemic lupus erythematosus. It could be due to rheumatoid arthritis. It could be due to crack heart. This is caused by cocaine abuse and most frequently seen lately would be the crack heart variety. Clinical manifestations of cardiomyopathy includes angina, syncope, fatigue, dyspnea on exertion, and its most common is severe exercise intolerance. Diagnostics would be EKG, chest radiograph, um, echocardiogram, CT scan, nuclear imaging studies, cardiac catheterization, and endomyocardial biopsy. Medical management includes meds like diuretics, ACE inhibitors, antidysrhythmics, beta blockers, automatic internal defibrillators is occasionally implanted. If the disease is advanced, cardiac transplant may be considered. Nursing interventions include relieving symptoms, monitor the patient's response to medications, avoid strenuous activity and dehydration. Space activities may be done also, which would allow rest periods. Disorders of the peripheral vascular system. Any abnormal condition that affects the blood vessels outside the heart and the lymphatic vessels fall under this umbrella. The peripheral vascular system consists of arteries, veins, and capillaries. The system supplies oxygen to the bilateral upper and bilateral lower extremities of the body and returns blood and carbon dioxide from those areas to the heart and lungs. The disorder of this system compromises circulation to the extremities. Structures here included would be the veins. They have a low pressure and valves that prevent backflow. The arteries have thicker walls, higher pressure, especially in the larger arteries. Arterioles, um, okay, are also a part of them. Those are your tiny arteries. Arteries are also the major controller of blood pressure and blood flow to organs and tissues. Capillaries are the place of oxygen and nutrient with waste product exchange. Both veins and arteries have three layers: the intima, media, and adventitia. Normal aging patterns. There's a decrease in elasticity and flexibility of the vessels as we age, and this causes a rise in blood pressure and increases the person's susceptibility to peripheral vascular disease. Risk factors. Non-modifiable ones would be age, arteriosclerotic changes may develop, gender, men more susceptible to arteriosclerotic changes, family history increases with risk. Modifiable factors include smoking, hypertension, hyperlipidemia, obesity, lack of exercise, and emotional stress. This increases the blood pressure, which in turn increases cholesterol production and increases vasoconstriction of the blood vessels. Arterial diseases, some of the risk factors modifiable would be smoking, hyperlipidemia, diabetes, hypertension, obesity, and family history. With varicose veins, it could be gender, family history, sedentary lifestyle, age increase, and race, whites more than any other ethnic group. With DVT or deep vein thrombosis, some risk factors would be damage to the vessel. Well, there's damage to the vessel, and so clotting disorders could be risk factors like sickle cell anemia and polycythemia vera. Venous stasis. With venous stasis, one could bed rest, immobility, and sedentary lifestyle and dehydration, cancer, and obesity could be culprits with venous stasis as well. Assessment. Arterial assessment. The first symptom is pain from arterial insufficiency and ischemia. There's a dull ache in the calf muscles. Leg fatigue and cramping also may persist. Pain is brought on by exercise and relieved by rest. This is called intermittent claudication. Pain may be felt in the thighs and buttocks area. As a condition becomes chronic, pain occurs at rest. At night, while lying down, bilateral lower extremities may have a burning, tingling, and numbness sensation. Palpate pulses and rate them from 0, which is absent, to +4, which is bounding and easily palpable. A Doppler ultrasound may be used if pulses are not easily palpable or per MD order. If Doppler is used, record the pulse as present or absent. For uniform assessment and documentation techniques for veins and arteries, use patches. This is an acronym, patches. P for pulses, A for appearance. And with the appearance, you want to look at color and whether or not an ulcer is present and things like that. The T is for temperature. If arterial problem, the affected extremity will be cold. If a venous problem, the affected extremity will feel normal or abnormally warm. The C is for capillary refill. We want it to be less than 2 seconds. Cap refill may be extended with peripheral vascular disease. The H is for hardness. Is the tissue supple or hard and inelastic? The E is for edema. Frequently indicates an acute process. Non-pitting edema may be seen with chronic conditions like venous insufficiency. S. The S is for sensation. Tingling or tenderness may result from peripheral tissue ischemia. Then we have venous assessment. There's decreased venous circulation, which leads to edema. Assess the skin for darker pigmentation, dryness, and scaling in the affected extremity. Chronic edema and stasis of blood may lead to ulceration of tissues, which would be stasis ulcers. The patient experiences aching to cramping, which is relieved by activity or elevating the extremity. Diagnostics would be the treadmill test, um, plethysmography, which assesses changes in blood volume in veins, and digital subtraction angiography, which involves IV contrast medium used to allow veins to be visualized via radiograph. Doppler ultrasound, a venography, which a contrast is placed in a foot vein to detect filling defects. And also it's the gold venography is also one of the gold standards to detect DVTs. Angiography, There, you are ingesting a contrast medium to visualize arteries on radiograph. D-dimer, here is a serum test used to detect the presence of a thrombus. Duplex scanning, this is a combination of ultrasound imaging techniques and Doppler capabilities to determine extent and location of thrombi. Hypertension. Normal blood pressure readings is less than 120 over 80 millimeters of mercury. Hypertension occurs when sustained elevated blood pressure is greater than 140 over 90 millimeters of mercury. Diagnostics are based on two or more elevated, or diagnosis rather, is based on two or more elevated blood pressures taken on separate occasions. There are various types of hypertension. We're going to look at some of them. Primary or essential hypertension has no known cause. It makes up 90 to 95% of all related cases. It often occurs between the ages of 25 to 55 years of age. It may be benign with uncomplicated hypertension. Malignant hypertension. This is with rapid progression and with organ damage, and with treatment, the prognosis is good. The course is rapidly fatal, however. Risk factors would be age, sex, men more than women until age 55, race, blacks more than whites, family history, diet, alcohol, taken in more than 1 ounce per day. This inhibits the release of ADH, obesity, smoking, which causes vasoconstriction, and sedentary lifestyle, stress, diabetes, and hyperlipidemia. Secondary hypertension. There is an identifiable cause like head trauma. It's usually reversible when the cause is treated. For example, with renal disease, it increases blood pressure results as well, but you still want to treat the cause. Causes of secondary hypertension would be renal vascular disease. Like I said, it increases your blood pressure results, and it affects renin and sodium, which does affect that blood pressure. Other causes of secondary hypertension would be vascular disease, endocrine diseases of the adrenal cortex like pheochromocytoma, pregnancy-induced hypertension, meds like oral contraceptives, head trauma, which increases intracranial pressure, and brain tumor. Okay, complications of hypertension would be that it affects the cardiac, renal, and neurologic systems and eyes. Signs and symptoms, they're often asymptomatic in early stages. In early morning, one might experience occipital headache, fatigue, dizziness, blurred vision, palpitations, angina, and epistasis. Prevention, where there are three types. Primary prevention would be education is the key. Identify and manage the modifiable risk factors and prevent hypertension from beginning in the first place. You also want to look at the diet. You want low to no salt diet, and foods that are good sources are eat foods that are good sources of potassium, magnesium, and calcium. Secondary prevention would be focusing on screening for hypertension, especially with those at great risk. Tertiary prevention is aimed at controlling hypertension and preventing complications. So a diet with fresh and frozen fruits and veggies are key, and you just want to read the labels and make sure a patient is informed as to what they're eating and the sodium contents and things there. Diagnosis of hypertension is determined with the average of two blood pressure readings on separate occasions, as I stated earlier. If systolic is greater than 140, or greater than or equal to 140, and if diastolic is greater than or equal to 90, that could possibly be, that's definitely considered hypertension. A complete history and physical is done to diagnose hypertension, and you look at labs of bun, creatinine, and electrolytes, CBC, fasting blood sugar, lipid profile, and calcium. A 12-lead EKG is done and chest x-ray. Treatments. Step 1 would be to modify the lifestyle. Step 2 would be to modify the lifestyle and with meds such as diuretics and beta blockers. Step 3 would be to increase the drug dosage. Substitute another drug or add another drug from a different class if needed to control that blood pressure. Step 4 would be to add a second or third drug from another class or a diuretic if it's not already present. Guidelines for accurate blood pressure readings. Of course, patient is seated with arms supported at the heart level. Appropriate size cuff is applied to the bare arm. No coffee nor smoking 30 minutes prior to. Calibrated measuring devices done. Usually that's the blood pressure cuff. Initially obtain blood pressure in both arms. You want to have a baseline. Nursing interventions will be to monitor blood pressure lying and standing, administer meds per order, monitor for edema, and assess for signs and symptoms of hypertension. Family teaching. Patient and family teachings include medications, giving rationale and making sure that they're compliant, discussing diet, exercise, and weight loss. Factors contributing to noncompliance would be finances, unclear instructions as to how to take it and why they're taking the medications, no written instructions, unpleasant side effects, memory deficits, inconvenient dosing schedule, lack of patient involvement, wellness. They don't understand the need for the medication. Hypertension and aging. There are changes in vascular system, okay, such as loss of elasticity, atherosclerosis, decreased baroreceptor receptors, reduced renal function, increased peripheral vascular resistance. So treatment and goals are the same as for younger folk. Elderly are more likely to experience adverse effects, however. With aging patients, they have decreased appetites and taste buds, and they're more prone to nutritional deficits. Fixed incomes often affect finances and patients' compliance with obtaining and taking their meds as they should. Um, Greater instances of orthostatic hypotension. Um, Dosages are started at low concentrations and are titrated to the blood pressure, and they gauge the improvement thereof. Sustained release products may enhance compliancy as well. Hypertensive crisis. This is life threatening, and they must get immediate attention, as we even will discuss in pharmacology. Usually through the use of IV medications to lower that blood pressure quickly and to prevent organ damage. It may be precipitated by abrupt withdrawal from hypertension meds that brought on a hypertensive crisis. Or pheochromocytoma could be the culprit, or CVA, which is cerebrovascular accident, or acute MI, or even intracranial hemorrhage might be the reasoning behind the onset of hypertensive crisis. Disorders of the arteries. There are a couple of disorders that we will discuss: arteriosclerosis, atherosclerosis, peripheral artery disease of the lower extremities known as PAD, arterial embolism, arterial aneurysm, thromboangiitis obliterans or Buerger's disease, and Raynaud's disease. Arteriosclerosis is characterized by thickening, loss of elasticity, and calcification of the arterial walls, resulting in decreased blood supply, and this is the underlying problem associated with peripheral vascular disorders. Atherosclerosis is characterized by yellowish plaques of cholesterol, lipids, and cellular debris in the inner layers of the walls of the large and medium sized vessels are affected as well. We will look at the others with the next upcoming slides. Peripheral arterial disease of the lower extremities, aka PAD. It's accompanied by narrowing or occlusion of the intima and the medial portions of the blood vessel walls. Common arteries affected in PAD of the lower extremities are iliac, common femoral arteries, and superficial femoral arteries. Pain is the first symptom that occurs from tissue ischemia, and pain with claudication subsides with rest. Signs and symptoms to watch for are the 5 P's of arterial occlusion, which are pain, pulselessness, pallor, paresthesia, and paralysis. Diagnostic tests include treadmill testing, digital subtraction angiography, Doppler ultrasound, MRI, and angiography. ABI also, and that stands for ankle brachial index, and it's a technique with a handheld Doppler that's used to measure the ratio of the ankle systolic blood pressure to the highest brachial index or brachial blood pressure. Medical management includes antiplatelet treatment, ACE inhibitors to decrease the heart risk and increase the blood flow to the heart. Intermittent claudication improves with Pletal or silostazol. Fibrinolytics or thrombolytics are given, encouraging the stopping of smoking. Surgical interventions for advanced disease would be embolectomy or endarterectomy or PTCA, which is percutaneous transluminal coronary angioplasty. Here, a balloon tip catheter is injected into the coronary artery, or even amputation may be done, especially if gangrene is present. Nursing interventions and patient teachings would be to prevent hazards of immobility by turning, positioning, deep breathing, range of motion, and isometric exercises, taking meds as ordered, placing patients' legs in a dependent position relative to the heart to improve peripheral blood flow, avoid raising the feet above the level of the heart, provide warmth to the extremities and keep room warm for vasodilation, avoid caffeine, smoking, don't cross legs, and avoid wearing tight clothing because this is constrictive. Arterial embolism. Blood clots are in the arterial bloodstream. They may originate in the heart from atrial dysrhythmias, MI, valvular heart disease, or heart failure. Clinical manifestations include distal pulses are absent, pain, affected extremities may become pale, cool, and numb. Shock may occur. Emboli is occluded, and this emboli in turn occludes the large artery. Diagnostics would be a Doppler, ultrasonography, and angiography. Medical managements include anticoagulants, fibrinolytics or thrombolytics, and endarterectomy or embolectomy may be done as well. Nursing interventions and patient teachings include monitoring skin color, temp, sensations, assessing peripheral pulses and cap refill, monitoring for edema. For both an embolus and a thrombus, of course, are clots that are present, could be possibly present. And bear in mind what they both are. A thrombus is a clot that broke off. Okay, but you monitor for those. Check incision if present for erythema, edema, and exudates. Promote circulation. Monitor for signs of bleeding, which is secondary to anticoagulation therapy also. Restrict alcohol intake, which increases anticoag effect. Nutrition. Here, um, steer clear of dark greens and yellow vegetables in the diet because these have vitamin K, which interact with anticoag therapy. So we want to bear that in mind as well. Arterial aneurysms. Here there's distended, weakened bulge in the arterial wall, and the side effects will be thoracic, abdominal aorta. Abdominal aorta, here the aortic is the most common um, area, um, and 3/4 of it is found in the abdomen. So it's a very common site for arterial aneurysms. Also, popliteal and femoral arteries are areas. Atherosclerosis is the most common cause. Smoking and hypertension are contributing factors. Risk increases with age and occurs more in men than women. Bear in mind that arterial aneurysm may be asymptomatic until they start leaking or pressing on other structures. Now let's look here at the different types of aneurysms. Thoracic aneurysm. Signs and symptoms are usually asymptomatic. One may have chest hoarseness and difficulty in swallowing, distended neck veins, especially if pressure is placed on the vena cava. With edema of upper extremities may be present, coughing and dyspnea if pressure is placed on the pulmonary structures. Abdominal aneurysms. One may experience back pain. That's a common symptom. Pulsating mass is visible. A visible pulsating mass. That's a hallmark clinical manifestation of abdominal aneurysms. Bruits may be auscultated if it ruptures. Severe back pain with bluish discoloration on patient's side or back and shock. They may go into shock. Definitely assess the blood pressure with this abdominal aortic aneurysm. Thoracoabdominal aneurysm. Here, the chest or shoulder pain may be experienced. Poor renal, GI, spinal cord outcome. Perfusion leads to renal failure, bowel ischemia, or paraplegia. Treatment and nursing interventions would be surgery. Non-surgical interventions would be hypertension meds, beta blockers, and decreased physical activity. Aortic dissection. Here, the inner layer tears and the blood gets between the layers. So it's most often seen with thoracic aorta and hypertensive men between ages 40 to 60 years of age. Most deaths occur within 30 days of onset. Rupture is the most common complication. Some signs and symptoms with the aortic dissection will be tearing or burning pain after vigorous movement, pain replaced by deep ache, and it can radiate. There are pulse deficits noted and discrepancies in blood pressure readings bilaterally. Treatments and nursing interventions would be if stable blood pressure and heart rate control is focused. Administer beta blockers to slow the heart rate and vasodilators to lower the blood pressure. Last resort would be surgical repair. Acute arterial occlusion. Here, signs and symptoms include look at the 5 P's, which was pain distal to the area of occlusion. Pallor progresses to cyanosis if occlusion is not resolved. Pulselessness distal to the occlusion. Paresthesia and paralysis due to nerve damage. Poikilothermy. Por- that's Poikilothermia. Poikilothermia. This is the inability to maintain skin temperature, cool or cold to touch, depending on room temperature. Sudden onset. Okay. Treatment for this would be surgery. It's reserved for severe cases. The limb is threatened. Thrombolytics, parenteral anticoags, or anticoags for long-term use. Nursing interventions, we want to monitor the pulses, distal to occlusion, and above the area, mark with a marker. Um, Protect the affected limb from injury, bed rest initially, and monitor appropriate lab values for therapeutic effectiveness and treatment. Chronic arterial occlusion. This is arteriosclerosis obliterans. It's most often in lower extremities. It's caused by atherosclerosis. It's more in men and with advancing age. Systemic disease may be present in more than one arterial bed. Signs and symptoms may be asymptomatic at first. Then ischemic ulcers over the bony prominences could be present, and that could lead to gangrene, and that's very common in that instance. Pain when exercising. This is intermittent claudication. Impotence in males if it involves the internal iliac artery. As the disease process advances, pain occurs at rest. Paresthesia, atrophy of the skin. The skin appears shiny in the affected area. Loss of hair. They could be pale when elevated, red or blue when dependent or lowered below the level of the heart. Treatment for this depends on the extent of the occlusion. A surgery that might be done is a PCTA or a bypass graft. Non-surgical things that could be done would be stopping smoking, regular walking program, meds, and controlling the lipid profile, diabetes, and hypertension, just controlling those factors. Nursing interventions include monitoring circulation, keeping the skin of the lower extremities clean and lubricated, not soaking the feet for extended periods of time, keeping any ulcers um, clean and dry. Okay, and ulcers are common complications that are hard to heal in this case. No restricted clothing and no crossing of the legs because this further compromises the circulation. Patient teaching of arterial occlusions include daily walking 45 to 60 minutes. Um, do it to the point of pain, then sit down and let the pain subside, then repeat the cycle. Wear cotton socks or hoses. Avoid trauma to the feet. Take care of any sores immediately. Follow up care. Perform follow up care. Nurse interventions of post-femoral popliteal bypass, especially. We want to assess respiratory status, pain, pulses, sensory motor function, edema, circulation, and the incision. Avoid use of the knee gatch on the bed. Um, this is an adjustable joint on the bed that flexes the knee and supports the legs. Some, bed cradle. This is the frame placed over the bed that positions the patient. Okay, so they might want to use the bed cradle, but avoid use definitely of the knee gatch. Thromboangiitis obliterans or Buerger's disease. This is an occlusive vascular condition in which the small and medium arteries become inflamed and thrombotic. Clinical manifestations where the most common symptom is pain with exercise, which affects the arch of the foot and with instep claudication. Okay. Um, when hands are involved, pain is bilateral. Do a risk factor assessment. Assess pulses for their presence. Note skin color and temperature on the affected extremities. Diagnostics, well, none are specific for Buerger's disease, and these patients have a higher level of hematocrit blood viscosity and red blood cell rigidity than patients with PAD. Medical management, we want to prevent the disease progression. Modify those risk factors that can be modified, like stopping smoking is the main focus. Excuse me. Nursing interventions and patient teachings include managing the risk factors, well-fitting shoes and socks, care of the patient to prevent necrosis and gangrene by hydrating and maintaining cleanliness. Those are some key things to bear in mind. Raynaud's disease or Raynaud's phenomenon. It's a chronic disease of unknown etiology. It mostly found in women. It consists of episodic vasospasms of the small skin arteries, primarily of the fingers. It's precipitated by cold, emotional stress, caffeine, and nicotine. Signs and symptoms include blanching followed by cyanosis, then by rhubarb. Occlusion is not complete and pulses are not affected. Sensation of numbness may be experienced, followed by throbbing, pain, tingling, and swelling. It may be treated with beta blockers and vasodilators. Patient teachings include keeping extremities warm, avoid contact with cold objects, no smoking, no caffeine. Brief warm water soaks may provide relief from vasospasms also. Disorders of the veins. We will look at three conditions associated: thrombophlebitis, varicose veins, and venous stasis ulcers. Deep vein thrombosis, or DVT. Signs and symptoms are pain and edema, increased circumference of calf and thigh, erythema, warmth and tenderness with superficial thrombophlebitis, positive Homan sign. This is a test in which the patient is supine and foot is dorsiflex and pain is experienced in the calf muscle. Treatment would be anticoagulant therapy, warm compresses, bed rest with elevation of the affected leg. Prevention for those at risk of DVT would be early ambulation, okay, in range of motion, and leg exercises with dorsiflexion of the foot, compression stockings or boots, adequate fluid intake, and low-dose anticoagulant therapy. Varicose veins or varicosities some causes are obesity, pregnancy, tight clothing, standing, family history even as well. Factors that worsen varicosities is overexposure to sun, use of hot tubs, tight clothing, high-heeled shoes, lack of exercise, prolonged standing or sitting. Signs and symptoms will be visible tortuous veins, skin thickening and pigmentation changes, venous stasis ulcers, cramp-like pain at night, pain after prolonged standing or during menstruation. Varicosities are irreversible. Diagnostics would be Doppler and venogram. Conservative treatment includes compression stockings, exercise, weight loss, regular period of leg elevation 2 to 3 times per day for 15 to 20 minutes above the level of the heart. Invasive treatment would be sclerotherapy. This is a medical treatment used to treat varicose veins and spider veins. Laser surgeries, catheter-assisted procedures, vein stripping, and ambulatory phlebectomy. Nursing care would be checking distal pulses. Do not gouge the knee. Elevate the foot of the bed to promote venous return. Monitor feet and toes for edema and color. Walk immediately or ASAP. Put stockings on first thing in the morning before getting out of bed. Patient teachings would be exercise, watch your weight and your diet, watch what you wear, elevate your legs, avoid long periods of sitting or standing, and do not cross your legs. Venous stasis ulcers. Treatment is elevation Special compression bandages rather than hoses over the open wounds. Dressing changes as ordered. Antibiotics for signs and symptoms of infection. Surgical debridement of conservative measures um, don't work. Surgical debridement of conservative measures typically don't work. Um, Nursing interventions include monitoring the wounds, dressing changes per order, monitoring for signs and symptoms of infection. Patient teaching includes taking preventative measures, diet to promote healing, and adequate rest. Monitoring that.